the next question actually follows very closely on the heels of this last discussion, and I thought it'd be useful to just present what look like complicated slides, and are for a reason, but also that that may help to focus some of the discussion. And that is that, I mean, we all recognize that clinical outcome is the coin of the realm. If we're not going to make people better in some way, whether it's pain or health or function, and we're going to make them better for some period of time, this is just not worth doing. No therapy is worth doing. And then Samia Viswanathan asked a question in the chat room about variation and the fact that not only is every patient different, and every patient differs in the comorbidities that they bring to the table and the severity of their disease and other things like stability and previous injury and so forth. But we differ in terms of the therapy. Now, the therapy that we're giving, if it's BMAC or PRP or one of these cellular therapies, is a function of the composition and the dose. And there's huge variation from patient to patient and even time to time when we make those preparations. And so there we struggle with that question of, what type of patient, what type of comorbidities, what type of disease, and how do we manage this variation in our lot-to-lot presentation, much less our execution and delivering it to the right place and these other factors that influence outcome. And if you go to the next slide. So that preparation, that composition of what we get in terms of the concentration and the prevalence of different cells is also dependent upon the donor state, the source of tissue, the harvest method, the way we isolate cells, the way we remove red cells, any selection processes. And so there we have tremendous number of variables to not only control, but to consider in getting a starting population, doing a process, and then getting an ending population. So if you go to the next slide, we have to struggle with this challenge of we have a starting population, we put it through some device, we have an ending population that may change the concentration of different types of cells, different types of cytokines or other factors that might have a role. And so these are huge sources of variation currently in what we do. And so now if we go to the next question, and again, this follows on the heels of the last discussion about what patients care about and how much variation are we struggling with, is we do need evidence. It's clear that there is something there because it does seem that people get better, and they get better at a magnitude that's larger than placebo in most cases, and it seems to have a substantial durability even in some cases, but we don't necessarily know just yet in whom we can expect that result and how to make that reliable. And so now if I'm a payer, or if I'm a patient, or if I'm a society running a national health system, what do I expect? And I'm interested in what the panelists feel. Do we have to reduce their pain by half? Do we have to do that for a period of 3 months or 6 months? Do we have to show that these therapies delay surgery to make them worth the cost? What's the threshold for you? Patients decide if they're paying, but other payers and nations decide if they're paying. We have to live up to some standard of how much relief, how confident are we, what duration, and are we influencing the rest of their lives and the rest of their care? And I may open up this to Dr. Murray first, and then go to Chris and to Nicolas.
Well, this question is quite pertinent for us. Obviously, I'm fully based in the National Health Service here, and we have the National Institute for Clinical Excellence, who will help us make decisions on stratifying treatments based on how we balance providing osteoarthritis drugs versus cancer drugs. And so we're largely based on a quality system. and the value that the National Health Service or NICE at the moment have put on a QALY, which is for those that aren't familiar, quality adjusted life years, is 20 to 30,000 British pounds. So we have to be able to demonstrate that that is that we can deliver what would be the equivalent of one QALY for that price, and so that is a kind of set across all specialties.
And how does that translate, Iain, into, is that because for some patients the benefit might be that they can continue to work in their current job.
Mm-hmm.
For other patients it might be that there's a 2-year delay in the need for surgery. For
Yes.
other patients it might be that they don't have to move out of their flat. How because that measure of benefit varies so much from patient to patient, how do you convert that into a dollar number, and how does the dollar number kind of come back to real life clinical situations that would be examples?
No, you're absolutely right, and that's the big challenge of it. I'm not sure exactly how the algorithm works, but it certainly takes into account whether the change in your symptoms, whether it extends both the quality and the length of your life. I'm not exactly sure how that is calculated here, to be honest. But I think the big challenge is making it fair and making it, and representative.
And Chris, how does this play out in your community in Korea and your practice and patients?
You mean the
Yeah, we can hear you.
Do you mean the evidences right now we have? So
well, no. What level of improvement do patients expect, or payers expect, or if Korea has a national health service, what level of improvement would they expect in order to justify the cost of these therapies?
Yeah. No, in Korea, the 4 stem cell drugs are released for the first time in maybe global, and one of them is the stem cell therapy for osteoarthritis or cartilage defect, and it is cost about $10,000 US maybe. So not that expensive in the States, right? But in Korea, it's maybe double the price of total knee arthroplasty, maybe 2 or 3 times expensive. So most of patients who are seeking the stem cell therapy are quite willing to pay much more than that one, maybe 20,000 or 30,000. They are willing to pay. But what is important thing is to what the stem cell therapy makes better. How much? So the degree of improvement, especially the structural improvement, they are most interested. So I don't think it's not the absolute amount of the money, but the regeneration quality should matter, and that the Korean people are really think about that one. So yeah, this is the situation in Korea, because maybe the only country who uses stem cells in legally.
I know in my practice, I just reflected that if I'm because I do arthroplasty, but I do offer these types of injection therapies to selected patients, and I probably would I would probably feel that I would do a disservice to a patient unless I could offer them at least a 50% reduction in pain for at least 6 months, and delay their need for surgery if they're thinking about arthroplasty, a year or more, ideally longer, because I recognize that the arthroplasty option for osteoarthritis is a pretty good one. There's a 95% chance of having an excellent pain result. There's durability. Probably average survival of knees now is 30 years, and so the idea of providing a therapy that denies them the opportunity to go down that path of predictability, unless it offers them something substantial and predictable, is a challenge. And I know, Nicolas, you face this in your practice. How do you approach this?
So I just wanted to comment. I mean, the way I approach it, I think there are two different aspects that are worth mentioning. One is from a patient's perspective, their response to a treatment, it's binary. They got better or they didn't get better. If you look at their satisfaction, because the question would be, I would do it again? Yes or no? And then we can discuss if they got partial, complete relief, or what level of relief. When we look at data from a clinical study, we need to look at what's the clinical significance of whatever difference we can measure, right? Sometimes we go through different studies, even in the arena of cell therapy or orthobiologics, and we can measure a difference. Now, if that difference makes a difference, that's a different story. That's why the first thing that I would say is that when we assess the clinical data, we have to use clinical significance measures of assessment of pain and function. So either if it's an MCID or an SCV, so a minimal clinical significant difference or a substantial clinical difference, or even like some kind of PAS assessment where you're looking at the patient acceptable state of symptoms, you need to look at the patient and the data as a whole and what kind of significance. And the reason I bring that up is that when we assess the literature or we determine the power of a study, we need to make sure that we're measuring a difference that is worth measuring. From a patient perspective, we need to present the data. And for some patients, perhaps a 20% difference would bring them satisfaction and they would do it again. For another patient, that might not be enough. But it needs to be driven by data and by clinical significance. Otherwise, we get into these statistical differences that we can establish between different groups that they might not have a clinical effect. And then when it comes to the question is if we can delay surgery or if patient can return to their activities of daily life, it remains a question.
So Nicolas, you and George both emphasized, which is my experience too, that where our expectations are based on clinical endpoints, reduce pain, delaying surgery, things like that. What about if we truly could demonstrate tissue regeneration? I'd like to ask Scott Bruder, how might that figure in at the FDA, at regulatory level? If we truly could demonstrate tissue regeneration, would that be even stronger evidence to justify cost for these therapies, even to justify ultimately third-party payers to cover these treatments? Because symptom improvement is so variable. And clearly it's what we have right now. But back to the question, apart from symptom modification, can these treatments be structure modification? So a question, Scott, is what if we could really demonstrate true tissue regeneration, structure modification? How would the FDA treat that?
So that's a great question, Scott. And there is this open issue of what's being referred to as DMOD, or disease modification of osteoarthritic drugs and devices. The agency put out a guidance several years ago, which was very, very skinny and basically asking people for input. There is no set standard for disease modification right now, and they're asking for thoughtful investigators to weigh in on that. What I can tell you, and based on what we know with rheumatoid arthritis, is they're looking at indeed a structural modification as one part that is durable for at least 2 years and tied to functional improvement. So if you showed, for example, thickening of articular cartilage, but the patient didn't have a reduction in pain or they didn't have an improvement in function, that doesn't matter, right? It's like with articular cartilage repair, you could see new cartilage formation in a focal defect, but if the patient's not feeling better, they don't have improved function, that's not going to carry the day. As Nicolas said, it's possible to show statistical improvements that don't meet MCID or minimally clinical important differences, and that is also a requirement from the FDA to gain approval. Once you have an approval, getting reimbursement, whether it's through Medicare or third-party payers, is somewhat of a standardized process in terms of having a sufficient number of peer-reviewed publications, having gone through a use case and a specialty, at least in the United States, a specialty society endorsement that then moves up to the AAOS reimbursement committee, who then makes a recommendation that then goes to the AMA for endorsement and recommendation. And then that application, as it were, goes to CMS for approval. If they weigh in that they believe that there is a meaningful evidentiary basis to support effectiveness, and naturally you're collecting economic data in this study as well, they'll recommend a specific code or reimbursement, and then that gets usually covered at a multiple by the third-party payers. Insurance and third-party payers pay more than Medicare.
Well, thank you. The reason I wanted to bring it up, so in distinguishing structure modification from symptom modifications, you make the important point. Yeah, if you regenerate tissue, but the patient still has symptoms, that's not effective. I can argue the other way. And here's the scenario quite simply and briefly. Young patient, meniscectomy, you do a subtotal meniscectomy. That patient will have no symptoms in the early years, but they're going to have a problem in the future. Now, if I can generate or demonstrate that is tissue regeneration early on, that could be significant. Now, the patient's not going to, if I have no meniscus, they have no pain in the early years. So I'm not going to show symptom improvement, but if I can demonstrate structure improvement, there I would argue with you, and your 17-year-old kid always took out a disc by meniscus. If I can demonstrate tissue regeneration, that should be significant. I think these are questions we have to wrestle with, or scenarios to think about as far as regeneration of tissue versus symptoms and how those may be discordant.
Yeah, I mean, for sure, you could imagine a lag period. But if I'm a payer, just having walked through this process before, if I'm a payer, I'm not sure that I want to pay $25,000 for that cell-based therapy to treat your 17-year-old kid until I know that, Scott, your therapeutic intervention did result in a benefit of them, even though it's several years down the road. That would be a fantastic study to do, but it will be timely and expensive.
Yeah, which is kind of why pharmacy has now developed some of those treatments, because the outcome may not be known for many years. So that's one of the central challenges in this whole area, certainly.